Thank you very much. We're going to move on to the topic of photodynamic therapy. So just stretch yourselves out a little bit. Stand up if you've heard of photodynamic therapy. Okay, not bad. Should make the introduction a little bit easier. Thank you. Please stand up if you've had photodynamic therapy. Okay, so I didn't see anybody in the room. Okay, so I think it's something that we need to know a little bit more about, and more importantly, know about the pros and cons. So I'd like to introduce David Loren from Thomas Jefferson University, who's going to speak for the motion in favor of photodynamic therapy. David.
Thank you. It seems I have my work cut out for me, since not that many people have heard of it, and no one here has had it, and that actually speaks to some of the challenges that we are experiencing in the field of photodynamic therapy. What I'd like to do is kind of walk you through this a little bit and explain to you what this is and why somebody might have it. The understanding of this starts with understanding the anatomic classification of cholangiocarcinoma. And I think we heard eloquently this morning that different types of cancer anatomically behave differently. There's the intrahepatic cholangiocarcinoma, which is driving much of our basic science that was presented today. But the most common type is this perihilar cholangiocarcinoma. And those patients are the individuals who have cancer that's located where the bile ducts branch. So this is the intrahepatic cholangiocarcinoma, and it happens up inside the liver, and it's a different type of cancer or disease pattern than what happens in this, the perihilar cholangiocarcinoma. So perihilar refers to those cancers that happen in this portion, the hilum of the liver, where the bile ducts branch, and again is different from extrahepatic cholangiocarcinoma that happens outside the liver or further down the bile ducts. Perihilar cholangiocarcinoma typically presents with jaundice because the tumors are based at the confluence of where those ducts come together. Patients may present with cholangitis, which is inflammation and infection of the bile ducts. The predisposing condition, which I'm sure many of you are aware of, primary sclerosing cholangitis, an inflammatory process of the bile ducts, can present in an identical fashion, making it hard to diagnose. And the complications that people develop from this most common type of cholangiocarcinoma, the perihilar type, are biliary obstruction, where patients have problems with infections in the liver and jaundice. That can lead secondarily from prolonged obstruction to failure of the liver. Later on in the course of what can happen to individuals can be other complications, but they tend to happen much later, months and months, because the initial presentation is that of jaundice and perhaps infection. Cure is surgical cure, and we've heard today both from patients, and there are those amongst you who've had surgery with an attempt to cure the cancer. Cholangiocarcinoma is difficult, but surgery is the only chance for cure. And then liver transplantation can be done for perihilar cholangiocarcinoma as well for a subgroup of patients who are eligible for it. Unfortunately, many patients are not eligible either for surgery or for transplant, and then we have to think about palliative strategies. So I'm going to share a story of a patient of mine. He's 63 years old. He was 63 years old when he was diagnosed, previously very, very healthy. And in fact, a very active windsurfer and sailor. So he was from California, then moved to Philadelphia. He should have, California with the windsurfing and the sailing, very happy there. Came to Philadelphia for his wife. He developed painless jaundice. He had an ERCP performed, but it did not resolve his biliary obstruction, his jaundice. Didn't open his bile ducts well enough, so he had drains placed from the outside, percutaneous drains placed. And he was planned for surgery. And at the time of his surgery, he was found that he had metastasized to his lymph nodes, and so his surgery was halted. At that point, he was eligible for a palliative approach. What can he do to treat the cancer but not to cure it? And there were a host of options available for him. And ultimately, this is in the course of when I met him, when he came to explore the options, the endoscopic options and photodynamic therapy, and another called radiofrequency ablation as treatment for his cholangiocarcinoma. A mainstay of therapy is to try to resolve the jaundice, try to keep the liver healthy so that patients don't have those complications from the obstruction. In very nice work done out of Paris, we see that the more liver that we can decompress, if we can open up half of the liver, that patients will do better. And how do they do better? They do better because they end up with having better palliation of their jaundice, which improves. Their drainage is more effective over time, and their likelihood of infection, cholangitis, is less. So they get fewer bouts of cholangitis, and there's a survival benefit to patients who have more of the liver opened up. So you can live longer if your liver is open because you're keeping your liver healthier by keeping those ducts open. So the focus is on keeping bile flow working well. And so then we say, okay, why would somebody choose an endoscopic approach for treatment of their cancer? Well, if we know that in perihilar cholangiocarcinoma, the dominant determinants of survival are whether or not people can have a functional liver and avoid infection, then if we can keep the bile flowing, we can minimize those complications. The endoscopic therapies are locally directed therapies, so they're done inside of the bile ducts. And they're done typically at 90-day intervals is how it's done in some centers. Others will have different approaches. But the way we approach it is at 90-day interval treatment. So patients will come, have a treatment, and then don't have another treatment. And if they choose this as sole therapy, don't have to see doctors again for 90 days. And importantly, the understanding that when the cancers are up in that high portion of the liver, multifocal bile duct obstruction is common. And when you use a laser therapy, that laser will travel up the bile even from where you're shining it because the laser is a light, and it'll travel up the bile, and it opens up areas that are otherwise you're not able to get the fiber, the laser fiber to. So the extent of the therapy extends beyond exactly where we're treating it to promote bile flow. Importantly, it doesn't preclude other therapies. So let me explain to you a little bit about how photodynamic therapy works. It's a two-step treatment. The first step is a medication is administered through the vein. This medication is a photosensitizer. It makes the cells sensitive to this specific laser that we use, and the medication has preferential uptake in the abnormal cancer cells and the dysplastic cells. The medication is given. 2 days later, an ERCP is performed. An ERCP is a test performed within the bile ducts, and the laser is advanced into the bile ducts. And at that time, the laser is illuminated for treatment. How does it work? The cancer cells are sensitive to the light. Remember, they have a lot of medication in them, this photosensitizing medication. And as a result, there are unstable oxygen molecules that get developed. These molecules end up causing cell death. There are a host of other things that happen as well. There are inflammatory mediators that will come about and cause a local inflammation. There's tissue ischemia and apoptosis, cell death, that occurs as a result of this reaction. And the cancer cells are most affected, again, because they have the highest concentration of the medication. Now, photodynamic therapy has been used for this cancer for cholangiocarcinoma for about 20 years now. And so what I'll take you through now are some of the data as we progress from retrospective data, looking at the patients who we've treated, to prospective data, to saying, okay, we're going to think about people not looking at them how they did, but how we're going to be doing going forward. So in this retrospective review of 184 cases, they were able to have patients who were, 111 of them were anticipated for surgery, but about half of the surgical patients couldn't get it. And so we end up with groups of 60, 56, and 68, three different groups that are roughly equal in size. 60 have surgery, 56 have stents, 68 have stents with photodynamic therapy. So these are stents without photodynamic therapy and stents with photodynamic therapy. Surgical complications are common. I think Matt presented earlier he needed to have another surgery. That's not an uncommon scenario. So as you know, these surgeries are significant surgeries for patients. And this bears out when we look at the data that I'll show you in just a moment. If we compare the photodynamic therapy group to the stent group, what we see is that despite the fact that the photodynamic therapy group had more advanced tumors as evidenced, can you go back one, please? Can you go back? Thank you. As evidenced by the fact of having more bismuth 4 tumors. Bismuth 4 are the tumors that are more advanced. Nonetheless, they had improved decrement in their bilirubin. They were able to maintain that decrement in their bilirubin over time, over a 3-month period when measured, and Importantly, their quality of life scores improved. And you can see this in the bottom graph here. These are quality of life with photodynamic therapy as opposed to without. The overall survival for patients who had surgery was the same as the photodynamic therapy group. So whether or not you had a curative surgical intent or stents with photodynamic therapy, you did the same. Without photodynamic therapy, not as well. In data that came out of the United States, this is a retrospective review of almost 50 patients. What we see is that the survival for patients who receive photodynamic therapy is 9 months longer than those who receive stent therapy. And what's important about this group, how it differs from prior, is that about half of patients had concomitant additional therapies. So we see in retrospective data about a 9-month benefit to treatment. This is a study looking at stents with photodynamic therapy as opposed to stents with chemotherapy. Okay, it's not stents alone. Stents with photodynamic therapy as opposed to stents with chemotherapy. This is out of the UK. And in those data, we see similarly a very significant improvement in survival in the patients having photodynamic therapy. And by the way, I apologize for that side of the room, but it's hard for me to get the angle on it over here. But you see a significant improvement in survival, in 1-year survival, and overall survival for patients who receive the photodynamic therapy as opposed to those who don't. And this is prospective data. This is following people forward, not randomizing patients to one arm or another, but following their treatment choices going forward. And then we have prospective randomized data. These are studies where patients are randomized to either receive photodynamic therapy or stent alone. And this was the landmark study that was initially done, and it's based on this that there's been a lot of enthusiasm, particularly in Germany, for photodynamic therapy. And this was a prospective randomized trial of 39 patients. The patients either had stent exchanges alone or photodynamic therapy with stents. And they had very strict inclusion criteria. You had to have a 3-centimeter mass. The biopsy had to be positive. That's a real challenge for some patients with cholangiocarcinoma, and they had a very rigorous follow-up protocol for these individuals. What was important about this study when they did the interim analysis, so what happens in a study is that part way through you look at the data and say, is it ethical to continue? Is it appropriate to continue this study? Are the patients doing equally well that we need to continue? Or is there something happening that we need to be aware of that's problematic for the patients? Or is one arm so much better than another? And what happened in this study was that they felt after the interim analysis that it was no longer ethical to withhold photodynamic therapy from those patients who were not receiving it because the benefit was so significant for them. And these are those data. The median survival for patients who receive photodynamic therapy is 490 days as opposed to 98 days those without. So that's a year benefit, survival benefit for those patients who are being treated. Importantly, one of the issues that is a common problem for patients and their oncologists is persistence of jaundice, that the bilirubin does not come down low enough for patients to be able to receive additional therapies. In fact, it's one of the dominant challenges that we have in perihilar cancers. And these data, along with data from other studies, pretty consistently demonstrate that your bilirubin, with the addition of photodynamic therapy, improves compared to stents alone. And that's borne out in this slide as well, where you can see that in the group that after stents alone, the bilirubin does not come down, but after photodynamic therapy, there's a significant decrement in the bilirubin. And this is something that I've observed in my patients as well. Importantly, in the study, all parameters of quality of life improved for patients receiving photodynamic therapy or PDT as opposed to those who did not receive it. In a second prospective randomized trial, again, patients are being randomized to one arm or another of biliary drainage with or without PDT. This was a study, 32 patients were randomized equally. The survival benefit appeared to be 21 months as opposed to 7 months, so just over a year benefit to patients undergoing therapy with PDT. And this is just a demonstrative. I think a picture's worth 1,000 words. So this is a patient of mine who underwent photodynamic therapy alone with no additional therapies whatsoever. And these are ERCP images. So I'm going to take you through this a little bit. What you see here, these dark areas are bile ducts. and it's X-ray material, that X-ray contrast that we see in the bile ducts, and then coming down, and in this image, you don't really see many bile ducts here. You see these big bile ducts on the outside because there's a tumor here that's obstructing all the bile ducts and causing all of these to be very dilated. And in this image, which is after treatment with photodynamic therapy for just over a year, you can see the bile ducts are now essentially back to normal size, and you can see the X-ray contrast coming down here, and we've been able to restore the biliary patency. Again, the dilated bile ducts, and then the restoration of the biliary patency, the bile ducts are open. The mass itself decreased in size from 3.5 down to 2 centimeters with photodynamic therapy alone sustained over this year time frame. The patient did not develop metastasis over the time of this. Ultimately, he did develop metastasis after just almost 2 years of therapy, and then moved on to have chemotherapy at that point. In our experience, we've also been able to use photodynamic therapy to remove percutaneous drains. So if you remember my patient who has drains, he had 2 drains coming out of his side, but he's a windsurfer and he is a sailor, and having drains out his side was not compatible with how he wanted to live his life when he knew that his time was limited. And we were able to remove his drains. And we're now up to 8 patients who have come to us with percutaneous drains. All 8 have been able to have their drains removed with the use of photodynamic therapy and internal stenting. And finally, photodynamic therapy has been used in small scenarios in order to help people achieve surgery. So this is a study that was done also out of Germany that looked at patients who had photodynamic therapy followed by surgery. They were individuals who were felt to be locally advanced. They had photodynamic therapy, 7 patients. This has only been presented in abstract form. This is 7 patients who were treated, and they were all able to have complete surgeries without residual disease and without margin-positive disease. And on the right, you'll see this is the pathology for my patient in whom we took this approach. This patient had photodynamic therapy accompanied by chemotherapy and radiation therapy, but had essentially a curative surgery intended to be curative with no tumor left behind after the time of surgery. Now, again, these have only been presented in abstract forms, and these are anecdotal experiences. But just to understand, there are ways to think about using ablative therapies and photodynamic therapy in particular that can help out patients with cholangiocarcinoma. Thank you.